Good afternoon, this is Dr. Rutledge, and I'm doing a video today to answer some questions that came up the other day. Good afternoon, this is Dr. Rutledge, and I'm going to talk about a couple of topics today that came up as questions to me. And instead of writing out an email to answer this, because of my limited typing skills, I thought I'd do this video. So we're going to touch on a couple of topics. One is the conversion of a Roux-en-Y gastric bypass to an MGB, a mini-gastric bypass. And as an introduction, we'll talk about the risks of the other kinds of commonly performed operations done in the United States today for weight loss, and that's the sleeve, the band, and the Roux-en-Y gastric bypass as compared to the MGB. We'll talk about the long-term outcomes in studies of those particular operations as compared to the 10-year and now 15-year data on the MGB. We'll talk about revision data from each of these types of operations. We'll talk about some of our survey data and also some examples from my own personal experience. This is only my own opinion, so other surgeons would have different ideas and different opinions, but these are my opinions, having had experience with 6,000 plus MGBs, and for the past 3 years I've had the good fortune to travel all around the world to participate with other surgeons in conferences, to watch them directly operate, to have them observe my operating techniques. And so these are my opinions. So let's begin by saying a few introductory remarks which are kind of critical of the band, the sleeve, and the Roux-en-Y. And I'm often told not to criticize those operations, but since those operations are widely performed, widely accepted, the question arises, why consider the MGB? I mean, if we have these other operations, the sleeve, the band, and the Roux-en-Y, and they're good, then there's no reason to take on and consider a new operation. And so my bias, my introductory remarks, are going to comment that I think that, in my opinion, and not everyone agrees, many people are advocates of the band or the sleeve or the Roux-en-Y, but in my opinion the data on those operations suggests significant limitations such that I don't think that they're generally good operations to offer to our patients. The band, very popular for a while around the world, particularly the country I've worked in quite a bit, India, almost completely abandoned. Many countries like England and France, which were very rabid advocates of the band, have given it up. And in the United States, the company that sells the lap band has been sold. The placements of the lap band is declining rapidly. Numerous studies suggest maybe a 50% success rate at 5 years, maybe less. So I think that, in my opinion, there's a lot of data to suggest the lap band is not a very good choice. It may be that of the 200,000 or so operations per year, if they were all done as lap bands, maybe 100,000 will have to be redone. So in my opinion, lap band is going to fail. Weight regain is common because the restrictive component forces the patients to begin to eat in a pathologic manner. So lap band, to me, I don't think is a very good choice. Second choice that I'd like to comment on is the Roux-en-Y, and particularly this question came up about the Roux-en-Y and asking about converting a Roux-en-Y to an MGB, and we'll get to that. But first we need to know and understand a little bit about the Roux-en-Y, and just briefly, let's point out that by most every study published, the Roux-en-Y is the most dangerous and deadly form of bariatric surgery offered today. By almost every study, it has the highest rate of complications, highest death rate, highest rate of early and late problems, and it has put into the lexicon of surgeons all around the world the fear of bowel obstruction after gastric bypass. So now every surgical textbook, every general surgeon trained around the world has been educated about this complication, the bowel obstruction after Roux-en-Y gastric bypass. The whole world has changed because of that introduction of a new complication. And the complication can be reported in up to 4 to 16%. Death rate and complication rates, as I say, are higher than any other kind of bariatric surgery except for maybe the BPD. And apropos this particular question, the rates of failure are relatively high. And we can summarize that briefly because the reason for the failure is kind of obvious in that the Roux-en-Y is primarily a restrictive procedure. The malabsorptive component is quite small, maybe 5% according to the studies that we quote in our paper. So, as a restrictive procedure, like other restrictive procedures, they tend to fail over time. Vertical banded gastroplasty, balloon gastroplasties in the past of other types, ring gastroplasty, horizontal gastroplasty, the lap band. Restrictive procedures are known to fail. They usually have good effects for the first several years, and then the bariatric community begins to turn away from them. So Roux-en-Y has a pretty high failure rate, and particularly, as we're going to talk about, if you review the data, there's a nice slide presentation from Dr. Coular on this topic, the revisions of Roux-en-Ys essentially double the risks of complications, leak rate, and death rate. So that when we point out, first of all, that the Roux-en-Y has the highest risk of any operative procedure, the ones we're going to talk about, and the four we're talking about in this tape are the Roux-en-Y, sleeve, band, and MGB. The Roux-en-Y is the most dangerous and most deadly, and the studies are clear that when you do a revision on a Roux-en-Y, you double the risk of leaks and complications. And again, I'll put a link to this. There's a nice slide presentation. Dr. Coular and I reviewed several dozen papers on this. And so revising Roux-en-Ys is interesting, and we're going to talk more about it, but they generally, the studies generally show poor results of revision of Roux-en-Y, and on top of that, doubling of the risk of complications, of the highest risk of complications of any bariatric procedure to begin with. Now, the sleeve is the new popular new kid on the block. The sleeve essentially is a purely restrictive procedure. There are studies suggesting there's hormonal and other genetic effects, but basically very similar, of course, in my opinion, and I think a lot of surgeons' opinion, very similar to the old vertical banded gastroplasty. It's a slightly longer restrictive area, but the obstruction is now from the pylorus and not the band that we used to put in. But basically a restrictive procedure, results show restrictive type weight loss, with weight loss that's inferior in most cases after the short term to MGB, to Roux-en-Y, and somewhat better than the band. But basically a restrictive procedure with a high incidence of acid reflux and thus long-term risk of esophageal cancer. The other thing is that we have long-term data now, and one of the best studies I think available is from Blue Cross Blue Shield, where they looked at the 6-year data of patients who had either a Roux-en-Y or a band, and what they found was that the long-term results showed that the patients who had either a Roux-en-Y or a band did worse than comparable patients who did not have the surgery. So let me say this again because I think it brings up to focus on the issue we want to talk about today. In other words, if you have a choice, say 6 years ago, of either having a band or a Roux-en-Y or not, what should you choose? And the theory is that the weight loss from the Roux-en-Y or the band in this 30,000 patient study of Blue Cross Blue Shield patients would help the patient, would result in better outcomes, would mean that the patient would have to be in the hospital less, would have to see the doctor less, and would have to need less medications. But in fact, that study showed the opposite. In this very large scale, unbiased study, performing a bariatric surgery on the patients harmed them. It made them sicker. That is to say, overall, the study showed that Roux-en-Y patients needed more doctor visits, more hospitalization, and more medications. The same was true for lap bands. Okay, so now we're back to why we're talking about the MGB. We're talking about the MGB because of data like this, because of experiences like this. If you look at the surgeons who are adopting the MGB around the world, they're surgeons who have performed the band, the sleeve, and the Roux-en-Y, and they've been dissatisfied. A quote from a recent surgeon who was talking to me from Calcutta said basically he was finding that patients were coming to him and saying their friend had a sleeve, their friend had a band, their friend or family member had a Roux-en-Y, and the outcome was poor, and I would like to have an MGB. And we think the reason behind that is that this data, which is beginning to grow, shows that the band, the Roux-en-Y, and the sleeve are problematic, that they have a moderately high incidence of failure, a moderately high incidence of associated complications. And so for that reason, the problem of what to do with the failed sleeve, failed band, failed Roux-en-Y comes up more often. So let's talk about that. The MGB in controlled prospective randomized trials has been found to be superior to the sleeve in resolution of diabetes. It's 50% more effective compared to sleeves. And it's equal to or better than the Roux-en-Y and up to 10-year follow-up. So basically the MGB is better than the other types of operations. Now, when these operations fail, the other operations, when a band fails, very good data in my experience is the best treatment for the patient in this case is a revision to MGB. There are other factors which I won't go into. It's not a trivial thing to undergo a revision of a band to MGB, but it is a good choice. Similarly, revision from sleeve to MGB is a good choice, but again, there are some details that many inexperienced MGB surgeons who are just adopting the MGB as this is their first operation have made some serious mistakes, and so in another video, if there's an interest, I'll comment on that. And finally, what about revision of Roux-en-Y to MGB? Well, let's first of all describe the technique. What we want to do is dissect into the left upper quadrant up to the area near the EG junction, at the junction between the stomach and the bowel at the gastrojejunostomy. We'll dissect this area cleanly and divide the gastrojejunostomy. We'll then dissect that roux limb free, bring it down, find the jejunojejunostomy, divide that, perform a jejunojejunostomy, then go back up and create a gastrogastrostomy. So you'll take the proximal gastric pouch and anastomose it to the bypass portion of the stomach. Once this is done, we'll pass an E-wall tube or a bougie across the gastrogastrostomy into the stomach. Then we'll turn our attention down to the crow's foot, to the lesser curvature of the stomach, dissect that area into the lesser sac, and then begin to create your gastric pouch. Now the gastric pouch normally goes parallel to the lesser curvature up to the area just lateral to the EG junction. But in this case, because of the previous roux pouch, what we will do is carry the staple line of the new neogastric pouch up to the area near the gastrogastrostomy and stay well lateral of that, giving us a very distorted mini-gastric bypass pouch. But this is the safest way to do it, stay well away from the gastrogastrostomy. Then the dissection will turn its attention to the ligament of Treitz. The bowel will be run to approximately 2 meters, and then a gastrojejunostomy will be performed. So it's very straightforward. The problem is that the length of the biliopancreatic limb needs to be adjusted, and that's part of maybe another video where we'll talk about that because of the damage done to the metabolism done by the Roux-en-Y, and this is similar to the damage that we see in the patients who've had a previous sleeve or a band. So we can't use the usual biliopancreatic limb length in a revision. Having said that and described that surgery, it should be obvious that that's a relatively major procedure, and particularly in the dissection, depending on the size of the gastric pouch, the amount of adhesions, the successful nature of the previous gastrojejunostomy. There may be extensive adhesions, and you may be dissecting up near or actually into the esophagus in this area. So this can turn an otherwise straightforward operation like the MGB into a disastrous procedure. So it's definitely reasonable, it can be done, it's highly dangerous and highly complicated. I would say at least double or triple the complication rate of a regular Roux-en-Y. Finally, I'd give my individual experience. We've had numerous patients who have fallen into the hands of surgeons who felt that the MGB was not a good choice for them, and they've converted them from Roux-en-Y to MGB. In the majority of those cases that I'm aware of, that resulted in weight regain. And in several of those cases, we've been approached to convert the MGB converted to Roux-en-Y back to MGB. And in 3 of those cases, we have done that, and they've resumed their weight loss. again modifying the MGB with that revision. Anyways, that's a little bit of a discussion about MGB, the revision, and the Roux-en-Y. I hope this answers some of your questions, and if you have other questions, please feel free to email me, and I'll put my email and telephone number on this video. Thanks. Bye.